This presentation is a synopsis of the Second International Consensus Meeting on Musculoskeletal Infection, which took place in July of 2018 in Philadelphia. This was a meeting that comprised several hundred delegates from almost 100 countries, which were gathered to help provide guidance with regards to optimizing our ability to care for our patients and provide the best possible treatment modalities with specific regards to foot and ankle surgery and foot and ankle infections. Surgeons, physicians, and scientists worked together for over 2 years to help more clearly delineate the best way to prevent, diagnose, and treat orthopedic infections. And in addition to discussing general infection concerns, these delegates worked in subspecialty groups to identify issues pertaining to those respective fields, including foot and ankle surgery. The findings and recommendations were published about a year later in a supplement of the July 2019 edition of Foot and Ankle International. And each task force, if you will, that was assigned to each subject or topic could either agree, disagree, or abstain from the recommendations that were ultimately made. And this obviously can provide important information for us to help decrease the morbidity that our patients suffer when they develop a postoperative infection or a infection without surgery. But it's also important to realize that these infections place a tremendous burden on our health system. For example, each infection following a total ankle replacement carries with it an estimated additional cost of about $20,000. So in no particular order, we're going to go through the questions or topics that were assigned to these groups. The first one was, what are the important risk factors that predispose a patient to an infection after TAR? Now, we'll say in the subsequent 3 years now, some of these have seemingly become less of a risk factor, if you will, and some more. With that said, the consensus, and there was 100% agreement with regards to the consensus for this question, was that the risk factors that are important to infection status post-total ankle arthroplasty were a preoperative diagnosis or comorbidity of inflammatory arthritis, prior ankle surgery, a BMI of under 19 or over 30, peripheral vascular disease, tobacco use, duration of surgery, age under 65, hypothyroidism, and chronic lung disease. Does intra-articular injection of corticosteroids increase the risk of periprosthetic joint infection? And there was a 90% or 92%, agreement with this, 8% disagreement, and 0 abstain. The risk of septic arthritis after an intra-articular steroid injection has been postulated to be about 1 out of every 70,000 intra-articular steroid injections. These recommendations, as are a lot of the recommendations regarding the care in all facets for total ankle replacement, are extrapolated from the total knee and total hip literature. But the answer is yes, possibly. The consensus is that there should be no injections within 3 months of the planned total ankle replacement. Should routine screening be in place for MRSA with regards to patients who are scheduled to undergo total ankle replacement? We know that patients receiving orthopedic implants or prosthesis are vulnerable for biofilm formation, and in the last 2 decades there's been an increase in community-acquired MRSA infections. These MRSA infections carry unique antibiotic resistance properties, high virulence characteristics, and pathogenetic capabilities. These also tend to affect younger, otherwise healthy patients. And when we note from the literature that Staph aureus strains isolated from skin and soft tissue infections match strain samples from nasal swabs about 85% of the time, it does seem that preoperative nasal swabs are a cost-effective means by which to help minimize these infections. However, the evidence is not conclusive regarding an association between rapid screening and the acquisition rate for MRSA or risk of MRSA-induced skin and soft tissue infections. But this protocol has seemed to decrease significantly the rates of deep Staph aureus infections in the total knee and total hip literature. So what pre-op optimization steps should be implemented to reduce surgical site infections and periprosthetic joint infections? Well, chlorhexidine foot baths 5 days prior to surgery seem to be effective. Optimizing the patient's total lymphocyte count, albumin, zinc, and transferrin levels seem to be important as well. And any deficiencies in these regards should be reversed or optimized as much as possible prior to surgery. What prophylactic antibiotics should be administered for total ankle replacement? Well, the level of evidence for this is strong, and there was 100% agreement among the delegates that ANSEF or cefazolin should be utilized in a weight-based manner, but at least 2 grams preoperatively. And this is because, of course, gram-positive cocci are the most common isolates found in surgical site infections and periprosthetic joint infections. The recommendation is to increase the ANSEF to 3 grams if the patient is over 120 kilograms. And it should be dispensed within 1 hour of surgery. There seems to be no benefit to doing it within 15 minutes or so. And it's strongly recommended that redosing be implemented if the surgery is greater than 1 to 2 half-lives of the antibiotic, which in the case of ANSEF is 1.5 to 2 hours. What are the benefits and risks of using vancomyosin powder during total ankle replacement? The literature tells us that there's a 73% decrease in surgical site infections and 80% decrease in periprosthetic joint infections and deep infections when it is used. The recommendation is for between 0.5 and 1 gram of vanco powder applied topically before closure. It is an incredibly cost-effective means by which to reduce the chances of infection. However, there are concerns including multi-drug resistance bacteria, local tissue irritation, hypersensitivity or anaphylaxis, impaired renal function, and increased seroma formation. I will tell you personally that in one of my visits to Duke in 2020, one of the surgeons there told me personally he has not had 1 single infection since he started to use vancomyosin powder. Is there a role for antibiotic impregnated dilute betadine or chlorhexidine irrigation in total ankle replacement surgery? We all know that the solution to pollution is dilution, but what do we use for dilution purposes? Saline is virtually the same as antibiotic impregnated saline. We know that. And chlorhexidine is similar to dilute betadine. So those two would seem to be optimal. However, we know that chlorhexidine can induce fibroblast toxicity even at low concentrations, and so the overwhelming recommendation was to use dilute betadine. What is the actual definition of an acute and chronic periprosthetic joint infection after TAR? Well, an acute infection is one that occurs within the first 90 days, and a chronic infection is one that occurs after 90 days. The diagnosis requires one major criterion or at least 3 of 5 minor criterion. A major criterion is the ID of 2 positive periprosthetic cultures with phenotypically identical organisms, or the presence of a sinus tract communicating with the joint. Minor criteria, which require 3 or more, are an elevated CRP and ESR, elevated synovial fluid white blood cell count, or a positive change of leukocyte esterase strip, elevated synovial fluid polymorpho nuclear site percentage, positive histological analysis of periprosthetic tissue, or a single positive culture. The threshold for these criteria differ when you're talking about or treating an acute versus a chronic infection. For example, the SED rate really is not helpful with no defined threshold for acute infections, but for chronic infections, it's over 30. The threshold for CRP in an acute infection is 100, while in a chronic infection it is 10. The synovial white blood cell count in the acute setting has a threshold of 10,000, and in a chronic infection, 3,000. Synovial PMN percentage in the acute setting is 90, in the chronic setting it's 80, and irrespective of the acuity of the infection, the threshold for histological analysis is greater than 5 neutrophils per high-powered field in 5 separate high-powered fields. So what things can we look for or key in on when we are talking with and examining patients whom we may feel have a periprosthetic joint infection? Well, one is any persistent pain with or without loosening should be worked up for an infection. The location of the pain can be helpful because it seems that pain more anteriorly or anteromedially is commonly caused by gutter impingement or stress reactions. Diffuse pain is more common in stiffness, loosening, or infection. I would also add that when the patient has pain can be an important key factor, as well as mechanical issues causing pain post-TAR are, as you might imagine, more commonplace and frequent when the patient is standing, walking, and using the prosthesis, whereas patients who have pain pretty much all the time are more likely to ultimately have a diagnosis of infection. Of course, we want to note any history of delayed wound healing or infection reported by the patient, particularly if it's a patient in whom is seeking an opinion and had a surgery done elsewhere. Moving away for a minute from total ankle arthroplasty, the age-old question of how to best differentiate an acute Chakra event from an acute infection. Well, there's physical features, labs and imaging, and so on and so forth that we can take into consideration. With regards to physical features, positive probe to bone is one of the most important. The reported sensitivity for this has ranged anywhere from 35 to 95%, but it was generally conceded that there is greater than a 50% chance that the patient has osteomyelitis if there is a positive probe to bone. Of course, Charcot typically affects the midfoot and lacks skin breakage. Osteomyelitis is typically in the forefoot and accompanied by a soft tissue infection or an ulcer. And with regards to the ulcer or the wound, if the wound is greater than 4.5 centimeters, there's a 3 times higher chance of underlying osteomyelitis. Labs and imaging studies play an important role in working up a potential infection or osteomyelitis, particularly in a patient who has Charcot and a open wound, which of course makes things more confusing. White blood cell count and a CRP are standard things that we order and look at. A SED rate, particularly a SED rate that's greater than 70, seems to be strongly associated with osteomyelitis. And keep in mind that the SED rate remains elevated longer than the other markers, making it more useful for tracking infection. Other markers include interleukin-6, and bone cultures specifically have a sensitivity of 90% and a specificity in 60% in the diagnosis of osteomyelitis in diabetic patients. Histology, though, is important. 40 to 60% of histologically proven positive cases of osteomyelitis had negative cultures. So the standard criteria or recommendations for diagnosing osteomyelitis is a positive culture with histological evidence of infection in a bone biopsy. Imaging has always played an important role in working up osteomyelitis, but which studies to order, when, and which carry more weight has been an ongoing debate in the literature. Keep in mind that plain film findings of osteomyelitis include demineralization, periosteal reaction, and cortical destruction, but these can lag behind by 2 to 3 weeks and require almost 50% loss of bone mass to detect. Because of this, most of us will quickly move to advanced imaging studies like an MRI, which has proven to be effective quite early on with a sensitivity of 90% and a specificity of 80%. In fact, a meta-analysis, which was reviewed in the journal, cited a superiority of MRI to nuclear imaging, plain films, and white blood cell studies. However, white blood cell studies or bone scans can be better in patients with metal implants, as you might imagine. There's a lot of additional details which I have left out, so I recommend you go back and review the article. But in summary, osteomyelitis is most likely when there's a positive bone biopsy confirmed with histopathology, an intraoperative finding of purulence in bone, intraosseous abscess found on MRI, and when there's exposed bone within a foot ulcer with corresponding changes in imaging. These are all things that would tend to suggest osteomyelitis is present. This is an algorithm with regards to periprosthetic joint infection regarding total ankle arthroplasty, which was included in the supplement review. And it guides you through the treatment of an early postoperative infection, which would be less than 4 weeks after the index procedure. And additionally, a recommendation with remote hematogenous infection, late chronic infection, and what to do when you are about to embark on a revision if there is intraoperative cultures which would suggest there is residual infection. This is another algorithm regarding infection after ankle or hindfoot fusion procedures. This is obviously too in-depth to go over word for word, so I recommend that you garner the journal and review it if you're interested. So these were the topics and the questions that just seemed to catch my eye and my interest, but I would recommend reviewing again the July 2019 supplement from Foot and Ankle International, because there's a plethora of information there, way too expansive to include in one isolated PowerPoint presentation. Thank you.